Yeah. Okay, Bismillah ar-Rahman ar-Rahim. Good morning. So today's session is about hormone replacement therapy. So what's the first thing that comes to your mind when someone tells you hormone replacement therapy? No. No, I mean comfort, fear, nervousness. What? Yeah, right. So we whenever we hear hormone replacement therapy, we think twice, and we feel that this is risky. It's linked to a lot of risk, right? Now we can explain a little bit more. So we're going to be talking about what are hormone replacement therapy, what is it indicated for, and I'm going to touch on even non-hormonal therapy for postmenopausal women. And this is what we treat these patients who are at a stage where they are either perimenopausal or postmenopausal, okay? And discuss risk and benefits. So when we say a patient or a female is at this stage of, she is a menopausal woman, and a person speaking, I hate how we translated it into Arabic, where we say sin al-yas, and I think it is it's really unfair because of the you're basically sentencing that female that's it, that's the end of your life, and this shouldn't be the case. Okay, so it's basically where the hormones. Some of our hormones, they decline in levels, and this is linked to series of symptoms. And these symptoms, initially, they are bothersome to the female. And this is why she will seek the help of her doctor, okay? When it's moderate to severe, this is where she says, okay, I need help, okay? There's still nothing entirely satisfactory. That's why there's more than one thing that she can use. And there is the race for a better option going on right now. So it's a range of symptoms. Initially, she will suffer from these hot flushes. That's the thing that she will really seek help for, mood swings. But later on, as time passes, years passes, she's going to be really worried about osteoporosis, okay? So this change in hormonal balance, unfortunately, it has this psychological factor where, females, they are linking it to aging, and this shouldn't be the case, okay? Why? First of all, the average age is increasing of females and males, but the average age is increasing worldwide. We are new treatments is emerging. Lifestyle, we're being more aware about healthy eating, healthy lifestyle. So the average age of female, we're talking about she's reaching into 90s. Okay, so if we're saying that this female will get menopause, let's say at around 51, 40 years. So this is the long span of time that you think that I'm old. You will go deteriorating in a very negative fashion. So it's very important that we perceive this as a stage and not perceive it as an aging as the end for your life. It's not a death sentence. This is what I try to say, okay? So the data shows that we have 25 million women globally that are entering menopause even earlier, okay? We have early ages of menopause, not sure why. And so we're talking about by the year 2030, and this is from the WHO, we have 1.2 billion postmenopausal women. Okay, so we're talking about the big thing here. We're talking that this is the norm. This should be the norm. Okay, the norm that you are acting, you should have you should really seek good quality of life during that span of time, because it's a long time. It's no more short. Okay, so there are different stages. The 4 stages of menopause, what we call the premenopause, which is the age that starts from the first period, let's say at age 12, and then around age 35, we call it premenopause, where the female is having a regular period every month, and no issues here. Okay, then we move to something called perimenopause. And perimenopause, this is where it starts to decline, but the female starts picking it up by saying, oh, my period is becoming shorter, I'm missing my period this month. So there is some fluctuation here. There's no regularity. We lose the regularity. But also that's the normal age, which is around maybe 40s, beginning of 40s, 45 onward, where this is what we call perimenopause, but the same symptoms are seen with premature menopause, where we have some women experience early menopause due to illness, genetics, medical procedures, so on and so forth. Now, how do we define the menopause? The menopause is basically the stage where we have no menstruation for 12 months. Okay, cessation of the menstrual cycle for 12 months, and this starts at an average age of 51, 50. So when we say menopause and postmenopause is basically later stages around 60 onwards. Okay, so what happens? As you all know, what happens is that the number of ovules or oocytes are diminishing, basically vanishing, and that's the main source of hormones, estrogen, progesterone production, and this will skip what we call the negative feedback to the hypothalamus. Remember when we discussed, not sure, was it last session, we said, where do we obtain FSH in the leg? Where do we obtain? If I want to give FSH to females, where do I get it? How do I extract it? Urine of who? Postmenopausal. Because there's no negative feedback, the levels of FSH are elevated, then we are able to detect them in the urine, extract them, and get FSH in the urine. Okay? Okay, symptoms is the whole thing. At the end of the day, we can't change or add ovaries, right? Or add oocytes, or add follicles. This is something that we cannot change. But the consequence of that, which is the symptoms that's bothering the female, is what we try to manage here. So what are the main symptoms? What are the main symptoms? The main symptoms, maybe initially we're talking about vasomotor symptoms. And vasomotor symptoms in the thermostat of the body, the hypothalamus, becomes very sensitive because of the low levels of estrogen. It becomes very sensitive to any slight changes in temperature, and this is where the patient experiences hot flushes. And we can take it lightly, but it can be really annoying for the female. She will be sweating, night sweats. She will not be able to sleep, along with the other symptoms, which is the mood changes. And see, the mood changes is linked to her self-esteem, to this new stage in her life. So this can go a long way, by the way. That's why we might ask her to, although she did not have any history of depression in that previous phase, we might ask her to start on SSRIs. Okay, and paroxetine is one of the good medications for this group of patients. Okay, so mood changes, vasomotor symptoms, and a group of symptoms. Now they are called genitourinary symptoms of menopause. This is the new term to express bladder and vaginal changes during that period. The vaginal dryness will atrophy incontinence so on and so forth. سموها genitourinary symptoms of menopause. Bone metabolism and cardiac function. Look, this image on the right hand side shows a lot of things, shows a long list of symptoms. Is it clear for you, the image, or we need to change it?
Yeah, it's clear.
It's clear?
Yeah.
Okay. So the other thing is the bone metabolism. Maybe that's what we need to focus on, because osteoporosis is something linked to low levels of hormones. And so we need to treat this in patients during that period. So bone metabolism, لأنه osteoclastic activity becomes elevated, and so the risk of fractures becomes more, and that's why the risk of osteoporosis is higher in females than males. Okay, cardiac function in terms of what? In terms of so many factors. In terms of increase in hypertension, risk of high blood pressure, because this might lead to some vasoconstriction, high lipids, lipid storage increases during that phase, the menopausal phase. So that's why we need to give HRT sometimes. Now, this is done on post-thorough assessment by the physician. So the physician needs to do the necessary tests and a clear consensus with the patient on what is needed to be done. Are we going to go non-pharmacological management, or is it going to be hormonal management or non-hormonal management? Okay, so we have three scenarios. So the thermostat, which is in the brain, the estrogen basically increases the threshold of temperature changes. So if there's no estrogen, that threshold is decreased. So any change, in any slight changes, will lead to vasodilation. So I feel hot, I'm sweating more. Okay. So it makes sense that if something is gone from the body, if I supply the body with the same hormone, then I should be good. Okay, I have deficiency in estrogen, let's provide estrogen, correct? I have a deficiency in iron, I would give iron supplement. That's the common sense, right? So the HRT hypothesis is when an installed hormonal deficiency generates symptoms in an individual, disturbing its well-being, it's expected that by adjusting the deficit, an improvement or even an offset of the symptoms should be reached. Okay, so hormone replacement therapy was the thing, was the therapeutic replenishment of estrogen with or without progestin. And this was done for years and years in the past. And physicians were comfortable to prescribe HRTs to females. Now what happened? Something came out. The HRT hypothesis was valid until what? Until 2002. So in 2002, came out a large randomized and placebo-controlled trial where they found that there's an increased risk of cardiovascular events and breast cancer rates in the patients who are taking HRTs. And this led to what we call HRT phobias. So physicians become phobic, literally phobic, to prescribe any HRT for females. Now, this study, I'm going to say it in Arabic, but then I'll translate it, where we say, الشيطان يقع في التفاصيل. Okay? So the devil is hidden in the details, and the details of the study. So that study, what was the the age of the females recruited in that study? What was was really crucial. If you are recruiting patients, most of them were 60 and above, then this is okay. But when we say menopausal or postmenopausal, we're talking about end of 40s, beginning of 50s. Okay, and this is where it's very critical for females to suffer from hot flashes and genitourinary symptoms or genitourinary menopausal symptoms. Okay, and so this was a bit harsh to judge the prescription or prescribing HRTs. And so from 2002, later on, they had an update. An update on the action of HRT is given in 2017, where the North American Menopausal Society relaxes. Relaxes, yani chill guys. It's not the end of the world. They're going to survive. They're going to be fine. So relax and encourage the attitude of clinicians regarding the use of hormonal preparations and menopause. But this is going to happen differently. It's going to happen through what? Through joint decision making. It's called patient-physician paradigm. Patient-physician paradigm. We talk, we tell you everything, we give you all the information, we both decide what's needed to be done. And thankfully, the new preparations are out in the market, which makes avoiding risk as much as possible. Okay, it's very important to know when do women begin HRT. Okay, so it shows here clearly that 48% started HRTs within a year after menopause. So within that year, it's the menopausal year. 17% they like to do it earlier, but that's a very low percentage. 10% 2 to 4 years after menopause, and 25% 5 or more years after menopause, which is way later stage in their life. Why is it the peak? The peak, it's because the peak of the symptoms is around that time. Later on, even the hot flushes would dissipate, would be gone. Everything, the woman would get used to her new status, so she would not complain as much. But the peak complaint would be during that phase, which is within a year after menopause, 48%. So what are the current recommendations? The current recommendations is only for patients with moderate to severe menopausal symptoms can be given HRTs. Okay? Can we give other things? Can we give non-estrogenic or non-hormonal therapy? Of course. But we're talking about the recommendation for HRTs. It should not be given as a mean of chronic disease prevention. We shouldn't give it, let me tell you, HRTs is not first-line therapy for treatment for osteoporosis. Now there are other things. And for osteoporosis, I need it for a good 5 years and maybe longer. So it should not be used as a mean for chronic disease prevention. Okay, so what is the key word? Is shortest period and lowest dosage possible to control symptoms effectively. And that's what the new preparations are trying to provide to the market, which is lowest dose possible. Okay, what else? They try to use smaller doses, something that is very similar to the natural amounts in the body, okay, and natural source of estrogen. So estradiol, which is or estrone, are natural format of this hormone, and you would see estradiol alone, estrone alone, okay, not ethinyl estradiol. So not the synthetic form, rather than the natural form of the estrogens. So there's a variety of regimens, and you would see variety of dosage forms. Yani, we have the oral form, but also we have the implants or patches. And this is very important to tell the difference between when is it preferable to use a patch over an oral pill. Okay, and also we have the vaginal rings, which is local, and this can help us a lot with the vaginal dryness and issues with libido, low libido, and pain during intercourse. So if you give HRTs locally, you would benefit way more than giving it orally. Okay? Now, we have two main types of HRTs. Either we give the combined hormone replacement therapy or estrogen-only hormone replacement therapy. When we can give HRT, estrogen-only HRTs? When do you think we can give HRTs estrogen-only without adding the progesterone to them? Huh?
Is it
Late in life? Okay, let's think of it as you've taken contraceptives, no? Okay, why do we give combined oral contraceptives? Okay, very good. So if I want to give estrogen only, when do you think I'm safe to give it alone? Yes. So if there's no uterus, then it's because I don't have an issue with hyperplasia, correct? So estrogen only for women who have had their uterus removed, this is a safe regimen to give estrogen alone. But usually we prefer to give estrogen and progestin or progestogene for women with menopausal symptoms who still have their uterus. Okay, now, again, back to the dosage form. We can give either a combination of ring intrauterine system, our loop, our ring, اللي هن بيكونوا progesterone, اللي هن levonorgestrine releasing intrauterine system, along with an oral estrogen. That's a combination, and that's fine. Okay, so we have you can give estrogen alone orally if you have the ring already there. So why? Why? For more than one reason. Sometimes this loop can be given to patients who are in the perimenopause because they're still in the childbearing age. They can get pregnant. There is still a period. And this could be as a contraceptive method. And it could be used for improving the libido and improving the dryness of the vagina, along with taking small doses of estrogen. You don't want to increase the dose. You can give small doses of estradiol to help you with the hot flushes as well. So you can give that combined therapy. Or you could have had the ring placed earlier than when you started experiencing these hot flushes, and then where you can, then adding the estrogen would be acceptable. It contains? Yeah, no, I'm not talking about this. You can have the ring where it contains both, but now they have this regimen where it's only progesterone only, levonorgestrine. Yes. So as your colleague mentioned, addition of progesterone, it's called it's a control method from getting, or the risk of getting endometrial cancer. Why? Because it inhibits the conversion of estrogen يعني sort of turns the active estrogen into a weaker one if we add progesterone, and it will inhibit DNA synthesis and reduce number of estrogen receptors. Okay, so this is what we're talking about. We have the option of pills, creams, pessaries, rings, implants, patches, sprays, gels, they are all good dosage forms. And if we want to discuss it from now, what could be an advantage of giving an implant or a patch over giving an oral dosage form?
Steady level.
Huh?
Steady level.
Good, steady level. What else?
Is it like secreted?
Better compliance.
Yes, better compliance. But what else?
Could it be in a secreted? Slowly.
Yes, which is this. We are making sure that the levels of estrogen are being very steady and regular, and there's no fluctuation, and that's amazing. What else? Think about it.
Cost.
Huh?
Cost of low.
Cost would be lower. No, actually, it's very easy to make a tablet. It's much cheaper. These are new things that you need certain layers and something that will go through the pores of the skin. So I don't think so. What else? Think about it.
It would last long.
Okay, it's the convenience, definitely. And it's a more convenient dosage form. It can stay there for months. There is this steady state. Perfect.
Are there less adverse effects?
How?
She will not forget. So
Huh?
they will not forget it.
Yeah. But how? How is less adverse effect? He said that, let's elaborate on this point. How is it less adverse effect?
It doesn't go through the GI.
Okay. That doesn't go through the GI. What happens?
Is it?
So maybe let's know the involved thing. I understand you. What else?
Maybe the metabolism into GI.
Huh?
Maybe in the GI it's nice to are more active. It could have more side effects.
Let's remember something. Let's remember.
Go deep.
Liver. Good. Let's talk about the liver. I like the liver. Huh?
First pass effect.
First pass effect. So if we give an oral form, then it will go through a first pass effect. So what does it mean? First pass effect.
More
Huh?
metabolizes into more active form of estrogen.
Not necessarily.
You will need higher doses.
Yes. So initially, because there's a first pass, I have to compensate for the first pass effect. Something will be gone, but I need the effect. So I have to give a higher dose. Let's start with this. What else? Oh, another tricky. Okay, you give up. Alas, what's in the liver? What's synthesized in the liver? Huh? Serum proteins. A lot of serum proteins are synthesized in the liver. Like what? Huh? Okay, albumin, proteins. Yes. All the protein binding. يعني ممكن يصير في cortisol protein binding. They will increase. Maybe we will have to make more cortisol, but also this will stimulate production of more coagulation factors. It's just you came and you shook the liver when you introduce these estrogen. Now this what will affect? How is that going to be? So high risk of thromboembolic disease. So people who have, let's say, a higher risk of getting deep vein thrombosis, we tell them, please do not take HRTs via the oral route. So alternatively, we give it through patches. Why? The patches get into the bloodstream, dumped into the bloodstream right away, overcomes the first pass effect. We're giving it in lower doses. It's giving me consistent levels of hormone. Okay. So this, I was supposed to say this towards the end, but I felt it's very important. And so it's available in systemic therapy, oral estrogen, But this combined, because see, we have contraceptives, they are combined oral contraceptives, right? Which could include estrogen and progesterone. But what's the difference? Someone tells you what's the difference between contraceptives, which contains estrogen and progesterone, and when I tell you combined oral contraceptives, or we call it estrogen progesterone therapy, EPT, which we use as a hormone replacement. What's the difference? So in terms of dosing, we're looking at a lower dose, okay? And what else? We try to use natural source of estrogen, estradiol, over levonorgestrel, okay? For HRT, okay? Now, so let's say we are complaining of what? So menopausal women, they complain of hot flushes, they complain of genitourinary symptoms, they complain of mood swings, correct? And later they will complain of osteoporosis, among other symptoms. Yani mood swings high is very important. So now we need to think of what other drugs can be added or given alone in certain cases where she is not complaining of anything but of mood swings, let's say, okay? So, or of low libido. Yani we have this issue of low libido, we have issue of pain during intercourse, and this also needs to be addressed. So, androgens. So imagine androgens is used to maintain a normal libido, okay? And sexual function in was a woman and potentially prevent the decline in bone quality and cognitive function. Do we use it a lot? Not really, not really. But please link that androgens plays a big role in improving the female libido, okay? Here, where I move to something called tibolone, and tibolone, trait tabao is Livial, very famous drug. It's a synthetic steroid molecule, which is it's basically it's prodrug. It's called progestogen. Post absorption, the metabolites can be estrogenic, progestogenic, and androgenic properties. Mainly, tibolone is used for low libido, for treatment of low libido. Okay? Now, the other group of drugs اللي هي نحن what are we scared of when we discuss HRTs?
Cancer.
Cancer, mainly breast cancer, okay? And so if I want to give something for treatment of osteoporosis, and I want it, of course, for a lengthy period, I need to avoid getting breast cancer, correct? So there is a group of drugs, they are called selective estrogen receptor modulators. From the word selective, yani they are agonists in certain tissues and antagonists in another. SERMs is one of them. We have two drugs here, raloxifene and ospemifene, and this is ospemifene. And so these drugs can be used for postmenopausal osteoporosis. Okay, Evista. It's the name Evista for raloxifene. Why? Because people who have a history of breast cancer, we cannot give them anything that's hormonally active. Okay? The other thing, طبعا, is bisphosphonate. And bisphosphonate is used, it's basically the first line therapy for the treatment of postmenopausal osteoporosis. Okay? So it comes first before raloxifene. And it's used for the treatment of osteoporosis. Can't treat anything else but osteoporosis. It can't treat the hot flushes, can't treat anything else but the osteoporosis. Clear? What about mood swings? Mood swings? Actually, HRT can be used to improve in mood swings with depression. Exercise is very important for that. The females need to do a lot of exercise during that period. And what else? SSRIs, and mainly paroxetine. Okay, so the studies about paroxetine are very good regarding postmenopausal depression. And venlafaxine اللي هي serotonin norepinephrine reuptake inhibitors is another example. You will see them written بالslide legend. Okay. So the key points is hormone therapy during menopausal transition should primarily be conducted based on the frequency and severity of symptoms. So lifestyle adjustment, yani let's be clear, without exercise, it's going to be very challenging for this phase to go. Even hot flushes, yani females are recommended to wear cotton clothes, ما يكونوا polyester, لأنه this will dissipate the heat and help her adjust. حتى soybeans, by the way, girls, soybean have some estrogenic activity. Vitamin E, there are studies that show that it is good for hot flushes. So this is so it's a combination between giving drugs and lifestyle adjustment. Okay, we give it in low doses. We have covered that completely. So benefits versus risk. What about cardiovascular events? This is very interesting. Do we give HRTs for patients with will it increase the cardiovascular risk if we give HRTs?
Yeah.
Yes, and why? Yes, and why?
Some women who are in the menopause phase, they have a higher risk of cardiovascular.
Exactly, why?
Coagulation factors will increase, but this is in case we're giving HRT.
Um,
Anyway, give or not, they're in.
Okay, why? So we're talking about cardiovascular diseases, يعني basically, you have anything? Yeah. Actually, this study, remember we said 2002, and they said the risk of cardiovascular diseases have increased significantly. And then they looked at the study and they found out that these patients were all 60 and above. And they did not recruit any patients who are end of 40s or 50s. And the duration, how long you're giving it. So they found out that if we give HRTs at an earlier stage of menopause, actually it should improve cardiovascular outcome, cardiovascular complications. In other words, why? Because adipose tissue will not be the accumulation of adipose tissue that takes place after, during the menopause period. And when you give HRTs, this actually بصير weight loss بدل weight gain. Okay, but if you give it at a later stage, this is where they have found that the risk has increased. So it depends on when are you starting HRTs in this regard, in the cardiovascular part. So major subject of controversy is a hypothesis, timing hypothesis. Positive cardiovascular effects of hormonal substitution are inversely correlated with the delay of initiating the treatment. If I start the treatment 60 and above, then the risk will increase. If I started early, end of 40s, beginning of 50s, this cardiovascular risk will be much, much lower. Okay? So for women who started the therapy within 10 years of reaching menopause, there's a reduced risk, whereas women who started the therapy more than 20 years, menopause, the risk significantly increase. Venous thromboembolism, we discussed this. What about venous thromboembolism? Benefits versus risk. So we have, it depends, if we're giving it orally, then the risk will increase. We do not give it orally because decrease of pulmonary embolism will be very high. We have to give it through patches. and bone loss, so musculoskeletal effects. طبعا studies have proven that if we give it in low doses, this will reduce the bone loss. But still, as we said, this is not our first-line therapy in treatment of osteoporosis. Our first-line therapy is bisphosphonate, mainly alendronate. There's a lot of studies, or risedronate. Then we go for SERMs, اللي هن raloxifene. Okay? And moving on to HRT and cancer, we have this positive association. So definitely patients who have a history, family history of breast cancer, we do not give HRTs. Okay. Contraindications: history of breast cancer, undiagnosed vaginal bleeding, history of endometrial cancer, active liver disease. ما حكينا cancer هنا. Cancer has nothing to do with it. Untreated endometrial hyperplasia and venous thromboembolism. These are the adverse effects for estrogen-related products or progesterone-related products. And I think we are done for today. You will go for something called continuous administration of HRTs or cyclical administration of HRTs. So we can give either cyclical form or continuous form. When do we give continuous and when do we give cyclical? الcyclical يعني شو؟ Cyclic يعني we have to mirror image in cycle of the female menstrual cycle. The progesterone usually is elevated in last 14 days. So we give estrogen initially, then last 14 days we give progesterone. This is when the female is still having her menstrual cycle going on. This is where we prefer to give the cyclical form of the oral HRT. In continuous, usually we give it for patients who have no menstrual cycle, is not interested to get a menstrual cycle, so it's continuous, and this is how it goes. يعطيكم العافية. This is my last session for this year. أتمنى لكم التوفيق. I think you're going next year. We're not going to be giving pharma for you next year. So it was a pleasure working with you, Sophie. Yeah.
Thank you.